Hello, my name is Arif Khwaja. I'm a nephrologist at the Sheffield Kidney Institute. Welcome to the first lecture in a series of 2 lectures on bone disease after kidney transplantation. So what I want to do in this lecture is focus on the following issues, and these I think are the key objectives of lecture 1. Firstly, for you all to have an understanding of the scale of bone disease post-transplantation, to understand a little bit about the different types of bone disease after transplantation. And then the last 2 things I want to talk about are the changes in bone mineral density that occur after transplantation and some changes in mineral metabolism. And then finally look at the impact of immunosuppression post-transplantation with respect to bone mineral density. So, when we talk about the scope of the problem, how common are fractures after transplantation? Well, this is old data from the United States, looking at a cohort of, I think, around 86 or so patients who were transplanted between the 1960s and 1990s. And as you can see, there was a much higher risk of fracture in this cohort. There was a higher than expected risk of vertebral fracture, and in this particular cohort, age and diabetes did associate with fracture risk. What about some larger data sets? So this is a recent publication looking at Medicare data, looking at first-time kidney transplants between 1997 and 210. And what you can see is there are around 597 hip fractures in this very large cohort, and you can see there was a significant impact of age on hip fracture, unsurprisingly, so that those over the age of 65, men or women, were much more likely to have a risk of fracture than those under the age of 65, and certainly women over the age of 65 had a higher risk than men over the age of 65. That age difference wasn't seen in people less than the age of 65. However, one of the things that seems to be emerging is that the actual prevalence of an incidence of hip fractures after transplantation is probably declining. So this is the same data set that was analysed in the previous slide, and what they're looking at here is the hazard ratio for the risk of hip fractures post-transplantation between 1997 and 2010, and you can see that generally the risk of hip fractures is declining over that period, and you can, and in this multivariate analysis, you can control for various variables such as demographic variables, comorbidity and dialysis, transplant variables, immunosuppression, and you can see that irrespective of all those variables, there's been a general decline in hip fracture rate, and that may partly be related to reduced changes in immunosuppression and in particular reduced steroid exposure. So in this systematic review, when you look at fracture risk, what the point that they make is that the fracture risks vary very significantly, and you've got to be very careful when you're interpreting the data, because data from the 1990s and early 2000s may not be representative of current practice, where steroid exposure is probably less. There are sort of a number of risk factors that really emerge, but I think the common risk factors are age, female sex, and diabetes, and smoking as well is associated in some studies, but I think age, female sex, diabetes, and obviously steroid exposure and era of transplantation are important risk factors as well. So how does the risk of hip fracture after transplantation compare to the risk of fracture to those on dialysis? Well, this is quite an interesting analysis, although quite an old analysis now, done back in 2002, which looked at USRDS data and looked at the relative risk of fracture in around 60,000 patients who were transplanted versus around 40,000 patients who were on dialysis but were on the waiting list. So the idea was that those people on the waiting list, if you like, acted as controls. And what you can see is that in the first sort of 2 to 3 years, there is a much higher risk of hip fracture in the transplanted population, but after 600 days, so certainly after three years, that sort of tends to decline. Okay, so very high early risk of fracture in patients transplanted, and even high, and the risk appears to be higher than in patients on dialysis. The caveat to this data is that it is quite old data and may not be representative of current practice. And just some evidence to suggest that diabetes is an important risk factor. So this is again USRDS database looking at the risks of fracture amongst non-diabetic patients, amongst diabetic patients who've had a pancreas kidney transplant, and amongst type 1 diabetic patients who've just had a kidney transplant alone. And you can see the diabetics have a higher risk of fracture than the non-diabetics, but actually the kidney pancreas transplants have a lower risk of fracture than the kidney-only transplants. Again, suggesting that diabetes and glycemic control is important in fracture risk. What about other kinds of bone disease beyond fracture? Well, avascular necrosis of the hip, which is obviously strongly associated with steroid use, is common, perhaps less common than was seen in this era from the 1990s. But this is USRDS data again, looking at 42,000 transplants, and you can see there was a relatively high number of patients who developed avascular necrosis after transplantation. Risk factors again were African American race, rejection, which may partly relate to steroid exposure, and diabetes. And in grey you can see the number of people who were hospitalised as a result of avascular necrosis, and the number of people who required, in black, the number of people who required a hip replacement 2 years post-transplantation. So I think what I've shown in these slides is to show you that fractures, bone disease is a common problem after transplantation. And let's now move on to the types of bone disease we see after transplantation. Well, really there's a whole range of bone disease we see after transplantation, and of course most patients will have significant, if you like, uremic osteodystrophy or renal osteodystrophy, and that is likely to persist post-transplantation. So patients may have osteoitis fibrosis cystica or high turnover bone disease. They may have adynamic bone disease, which predates a transplant, which persists post-transplantation. They may have osteomalacia, which, if you like, represents a deficit in mineralization of the bone. They may have dialysis-related amyloid, or they may have pre-existing osteoporosis, which reflects a reduction in bone mineral density, or they may develop osteoporosis, of course, after the transplant. And the important point here is that these are all histological diagnoses or diagnoses made on scanning, and the biomarkers really are very poorly predictive of underlying bone structure and bone histology. So using PTH to work out whether someone's got high turnover bone disease doesn't really work, because PTH is, particularly in the transplant population, is actually very poorly predictive of underlying bone histology. So this slide just, if you like, emphasises the point that I've just made, that pre-existing bone disease persists post-transplantation and is associated with adverse outcomes. And of course, as well as the pre-existing bone disease, there are other risk factors: steroid use, hyperparathyroidism post-transplantation, perhaps vitamin D deficiency may contribute to osteomalacia. Patients post-transplantation are quite commonly hypophosphatemic. That may contribute to osteomalacia, and obviously that all then leads to these patient-centred outcomes of bone pain and fracture, and these are associated also with a higher risk of cardiovascular disease and mortality. Now, what happens to bone disease post-transplantation? There's been a lot of work that's looked at bone density post-transplantation, but very little work that's looked at if you like, the evolution of bone disease post-transplantation. So what do we mean by that? Somebody who had osteodystrophy pre-transplantation, what happens to the osteodystrophy post-transplantation? And this is really the only study that looks at that. And in this study, they basically did a bone biopsy pre-transplantation and then another biopsy 6 months post-transplantation. A very small study. But what you see really is that in some people, bone disease improves, adynamic bone disease may get better in some people, but in some people it persists. In some people, they may get worsening of their bone disease. So some people here with mild bone disease developing adynamic bone disease afterwards. So post-transplant bone disease or pre-existing uremic renal osteodystrophy persists post-transplantation, although it may evolve, and the evolution obviously will depend on the GFR of the transplanted organ, of the medication that's being used, and obviously the pre-existing disease. This is old data looking at bone biopsies that were done in a cohort of I think around 50 or 60 patients about 5 years post-transplantation. And what you can see is that a lot of people have abnormal bone. So there are lots of different parameters you can look at, whether it's bone volume, bone turnover, osteoblast number, etc. And in the middle you see normal, and on the right and left you see low and high. And you can see that yes, some parameters are normal, but very few patients have normal parameters in total. So a high degree of abnormality of bone structure after transplantation, and I think therefore the learning point from this slide is that bone abnormalities don't resolve post-transplantation, although they may well improve. And in this particular cohort there was a reduction in bone volume. A significant number of patients had osteomalacia. Okay. What about the metabolic changes post-transplantation? Because obviously they may impact on bone disease. And I'll just read these out because I think that these are just important changes you need to be aware of. So PTH declines by about 50% 6 months post-transplantation, but remains elevated in at least 25% in 1 year post-transplantation. And although there's a poor correlation between PTH and bone turnover, PTH that persists after transplantation, or hyperparathyroidism that persists after transplantation, is associated with fracture rate. You can actually, if you image the parathyroid glands, you can actually see some shrinkage of the parathyroid glands after transplantation. You get changes in calcium, as you get a fall in the first week and then a rise. Hypophosphatemia and hyperphosphaturia are common, and there are probably multiple reasons for this, including obviously elevations in PTH. PTH is obviously a phosphaturic hormone. There's increased FGF23, which will increase the expression of the sodium phosphate cotransporter, which again increases phosphate excretion. And there may be increased tubular sensitivity to PTH in the transplant organ. And what happens to vitamin D? Levels of vitamin D may improve, but they may not be appropriate for the level of PTH. So just some examples of what happens to, for example, parathyroid hormone and phosphate after transplantation. So in the right-hand panel, this is parathyroid hormone. These are patients on PD, and when a patient is transplanted, which is in the dotted line here, the parathyroid hormone levels fall in comparison to, say, somebody who's been switched from PD to hemo. These are the black lines here. The parathyroid hormones continue to rise. So certainly PTH falls post-transplantation compared to just staying on dialysis, and unsurprisingly phosphate falls as well. So you you get transplanted here, you're on PD, you get transplanted here, your phosphate levels fall very rapidly. You get switched to hemo, your phosphate levels, if anything, stay static or rise. We talked about changes in calcium post-transplantation. This was a Belgian study of 201 renal transplant recipients at the time of transplantation, and then followed them up for 3 months. And you saw this sort of rapid fall in calcium and early on in post-transplantation that gradually resolved. And the fall in calcium was most pronounced in those with a low PTH, and that implies that there are sort of impaired mechanisms for calcium homeostasis, and the calcium then probably rises after a while due to PTH-mediated release of calcium from the skeleton. Okay, what about bone mineral density and mineral metabolism? What happens after transplantation? So let's just talk about bone mineral density. So roughly anywhere between 5 and you'll get anywhere between 5 to 20% loss in bone mineral density in the first 6 months after transplantation, and the annual loss in lumbar bone mineral density can be between 0.5% and 4.5%. The relationship between bone mineral density and fracture risk is not as robust in the transplant population as in the general population. In the general population, we know that low bone mineral density correlates with fractures. There is evidence in the transplant population as well, but it's not quite as tight as in the general population. And the fracture risk is nearly sort of 4 times higher in the transplant population than the general population, but with time that risk of fracture reduces to roughly twice that in the general population at 10 years. This was a small, this study was a small study looking at 19 patients who'd had kidney pancreas transplants, but it makes the point that when you look at, when you measure bone mineral density using a DEXA scan, you get a significant loss in the first 6 months, and then you get a stabilisation of bone mineral density thereafter. And this is a really nice study that was published not very long ago from France, and it's from Strasbourg, and this was a retrospective analysis of 143 consecutive transplant patients. And what they found was that PTH, parathyroid hormone, 3 months post transplant was an independent risk factor for fracture risk. So these are people with PTH of less than 130 nanograms per litre and a PTH of greater than 130 nanograms per litre, and you can see a significant difference in fracture risk between the high level of PTH and low level of PTH. So PTH, hyperparathyroidism, is a risk factor for fractures post-transplantation. Okay, and let's just delve into the impact of parathyroid hormone in a bit more detail. So this is a study that was published in 2014, and this looked at 47 patients who had early steroid withdrawal, and they were followed up over a year with DEXA, but also with high resolution CT, which allows you to image the sort of cortical bone in a lot of detail. And you can see that the scatter plot shows that those patients with higher PTHs tended to lose more cortical bone. This is imaging data from the radius. But so higher PTHs are associated with increased loss of cortical bone. The relationship with trabecular bone isn't quite, is slightly different. So there seems to be a bimodal relationship between parathyroid hormone and trabecular bone loss. So in the dark line here, in the black line, you have people with a PTH of, in the black line here you'll have people with a PTH of between 100 and 140, and in the dotted lines you've got PTH is either low, less than 100, or high, more than 140 picograms per mil. And what you can see is that in the low or high group there's a loss in trabecular density, and you can use that data on high resolution CT to kind of calculate whole bone stiffness and strength, and you can see there's a loss in bone strength in those with a low PTH or a high PTH. So different bits of bone, cortical bone and trabecular bone, are affected differentially by parathyroid hormone. Finally, let's just look at the impact of immunosuppression, which we've talked about a little bit already, on bone disease post-transplantation. And really what I'm talking about here predominantly are steroids. So steroids have sort of multiple effects. They inhibit osteoblast proliferation, which of course can then have an impact on bone mineral density. They increase osteoclastic activity by increasing rank ligand. They may reduce calcium absorption and increase urinary calcium excretion. And all these combine to lead to a loss in bone mineral density. Calcineurin inhibitors may or may not do things to the bone. We know that calcineurin inhibitors can cause vasoconstriction, and some have postulated that bone pain may be related to intra-bone sort of vasoconstriction of small blood vessels within the bone, but they also have other activity in vitro. They can stimulate osteoclastic activity, and of course that may result in bone loss, but that's predominantly derived from in vitro data. So what is the impact of steroid and steroid dosage on bone bone disease post-transplantation? So this is a study a little while ago looking at 57 adult transplant patients from the States who had a bone biopsy around 5 years post-transplantation. And if you look at in the left-hand panel here, bone turnover, and in the right-hand panel, bone volume over tissue volume, you can see steroids not only reduce bone turnover. The higher the steroid dose, the more likely you are to have less turnover of bone. You also get a reduction in bone volume as well in those with higher doses of steroids. Now, obviously steroids contribute massively to bone disease post-transplantation, but that's not the only, steroids aren't the only reason why people fracture. And that was quite nicely shown in this bit of data, which was an analysis of 175 patients who'd had various solid organ transplants, who'd received no more than 6 months of corticosteroids. And you can see that fractures persist in the sort of kidney group or in the kidney pancreas group, even in spite of stopping steroids relatively early. And this is more clearly shown in this analysis of the UNOS database, which looked at roughly 77,340 patients who were followed up for 1,500, just under 1,500 days. There were about 2,395 fractures in the whole cohort, but you could see there was a 31% reduction in fracture rate in those who were steroid-free. These are people who were discharged from hospital not on any steroids. So that's what we mean by steroid-free. They may have had steroids at their first during the time of their admission, but on discharge they had no steroids. But you can see that the fracture risk isn't zero. There is still a risk of fractures persist post-transplantation. It's not zero, but minimising steroid dose does attenuate fracture risk. And steroid withdrawal may have a sort of a differential effect on the skeleton in the same way that PTH did. So this is the same study that I mentioned earlier, where they looked at 47 patients who had their steroids withdrawn at day 3, and this is looking at the radius and in the bottom panel, the hip, in the middle panel, the lumbar spine, and you can see there's no real loss in bone mineral density at the lumbar spine. No real loss at the femoral neck, but there is a loss at the radius of bone mineral density, again suggesting that even in this group in whom steroids were withdrawn, you're getting bone loss presumably because of elevations in PTH. So just to conclude from this fracture, what did I say? Well, bone disease and fractures are common post-transplantation. Fracture risk is determined both by bone density, i.e. osteoporosis, but also bone quality, and what I mean by that is pre-existing renal osteodystrophy. Fractures persist post-transplantation even in the era of minimal steroids. and osteomalacia and adynamic bone disease are common post-transplantation. Hyperparathyroidism and steroids are major risk factors for fractures post-transplantation, as of course is female sex and diabetes. Thank you very much, and we'll now move on to the second lecture on bone disease shortly.